Oh, there we go. Okay. So the case we're going to be looking at today is that of a 38-year-old female patient. She's a healthcare worker from Cape Town. She's got no medical conditions or comorbidities. She's HIV negative and COVID-19 vaccinated. She presented on the 10th of July to Odyssean Hospital with a 7-day history of acute gastroenteritis and more recently a 3-day history of cough and fever. She had no other symptoms of COVID-19. So she'd recently returned from a holiday trip where she was traveling around the country. She drove to Mthatha, then to East London, before flying to Johannesburg and then George. She said she had a great time with plenty of recreational activities. Okay, so on clinical examination, she was generally well looking, apart from a degree of pallor, and the rest of the examination was actually relatively unremarkable. Her platelets were a bit low, as you can see here, and as a result, she was thrombocytopenic. Creatinine and urea were elevated. Her conjugated bili was elevated. The ALT and AST also elevated. Her red cell count was low, and she had a corresponding low HB of 7.7 with an elevated reticulocyte count. But she had a normal white cell count. So thoughts at this stage. So we put together a differential diagnosis based on this information, and we obviously thought COVID based on the current climate, traveler's diarrhea based on their history of traveling, and also leptospirosis based on the patient's history of having fried and been in the veldt and around rivers in the Eastern Cape. We'd also think of malaria based on the patient's symptoms, but the history of travel just didn't match. So there's a bit more information that I withhold from you. So her laboratory investigations revealed that she was COVID positive on PCR, and she also had a rapid malaria test done, which came back as positive. So I'm now actually going to hand over to Dr. Parker from hematology, who's kindly agreed to take us through the patient's microscopy. So Dr. Parker, if you wouldn't mind unmuting yourself.
Hello, it's Dr. Maseko speaking. I'm not sure if Dr. Parker is going to be able to join us. She's busy reporting some morphology, but I can sort of like take you through to morphology. So when I looked at the slide, when you look at the kit, the rapid test kit, if you go back to that previous slide, you can see that the test has worked because the control was positive, and the T1 and the T2 are both positive, but then the T1 is weak positive. And if you can sort of like look at the interpretation, so if it was only 2 lines, only on the control and the T1, we will definitely be sure that we are talking about the Plasmodium falciparum. But then if in case of 3 lines where the control is positive as well as the T1 and the T2 would be positive, we would also still be thinking of a Plasmodium falciparum, but a mixed infection could not still be excluded in that case. So then when you look at the peripheral smear, you can go to the peripheral smear, please. We do the parasite count. So you can sort of like agree with me that the parasite count was so high. The patient had a high parasitemia count of at least 5%. And the red cells morphology, they were normal in size and in shape, and then they were not sort of like enlarged. And then you could also like see some multiple infected red cells there, where you actually like see more than 1 parasite infected. So that would sort of like suggest more of a Plasmodium falciparum than any other than the ovale or malaria or the vivax. Because I mean, if you have to look at the vivax and the ovale, the red cell size and then the shape, it will sort of like give it away. So in these sites, although some of them are sort of like fimbriated, but then the cell, the actual cell is normal in size, and then you are seeing all these trophozoites with a ring shape, a chromatin dot. Sometimes, especially that one on the top here, has a double chromatin. So you would also that will also suggest of a Plasmodium falciparum. And then here you are also seeing the marginal form on this slide, there was also like scanty gametocyte that are crescently shaped, although we couldn't like get the actual photo of those scanty gametocytes that we saw. And then there were no also other like the hemoid, the hemozoins, which are those malaria parasites that you see on the other white cells. So those ones, they sort of like speak to the severity of the malaria itself. So we were comfortable to call it a Plasmodium falciparum, but then in addition, we had to do the PCR, which came back as positive. I think they're gonna load the results just yet from PathCare, where it actually like agrees with one malaria species, the Plasmodium falciparum. So that is a thick smear that you are looking at, and then it only shows that there is in fact a malaria parasite, but then unfortunately on that thick smear, you cannot sort of like differentiate which species is that. But then it tells you that there is a malaria parasite. Thank you.
Cool, thank you so much, Doctor, I really appreciate it. So based on these results, it was confirmed that the patient had malaria in addition to COVID-19. However, her recent travel history was that of having spent time in airports, cars, and public transport, but did not indicate that she had traveled to a known malaria area. As shown in this image, moderate and low malaria risk areas in South Africa are largely confined to parts of Limpopo, Mpumalanga, and northernmost areas of KZN. This raised the question as to how the patient came to acquire malaria. The most likely explanation would be either an inaccurate history or that this was a case of airport malaria. As the patient was adamant about her travel history, as well as a lack of recent blood transfusions, it was decided that airport malaria was the most appropriate explanation for her infection. Airport malaria, which is also known as taxi, or more accurately, Odyssean malaria, refers to malaria infection that has taken place outside the recognized borders of an endemic malaria area. Tang et al. Describes how the patient was exposed to the vector, being the mosquito, outside its recognized habitat. For this to occur, the mosquito will have needed to have been transported from its natural and recognized habitation. This has been documented in cases where aeroplanes, buses, and taxis from endemic areas have brought mosquito stowaways to non-endemic regions, where inoculation has then taken place. The use of the label Odyssean malaria seeks to eliminate the confusion that terms such as airport and taxi malaria can cause, as these can be misleading, as infection can take place outside of these two settings. In an article in the South African Medical Journal, Frayn et al. Explains how the label of Odyssean malaria is an ode to the Greek mythical hero Odysseus, who undertook a perilous journey around the ancient world. Throughout his travels, he overcame the odds to achieve his goal of returning home to his beloved wife and family. The authors point out that this is not unlike the culprit vector mosquito, who despite numerous obstacles is able to survive unfamiliar temperatures and being killed by other organisms to subsequently infect unwitting humans far from its natural habitat. Professor Isaacson, in a review of the topic from the late 80s published in the WHO Bulletin, explained a number of theories regarding the role of airplanes in acting as vectors for these vectors. He cited a study which found around 150 mosquitoes in 27 aircraft that had landed at Nairobi Airport, which could have been attracted to the artificial light and heat generated by airplanes. Despite disinfection procedures, mosquitoes have continued to be found stowing away aboard traveling aircraft, with the wheelbase being cited as potentially important sites of increased survival. Prof. Isaacson also explained how these mosquitoes can then feed in a small radius after disembarkation or be transported further via motor vehicle. And the Frayn article explained that this radius is around 1.5 kilometers. Internationally, Odyssean malaria is uncommon, but increases in air travel have seen a small rise in cases. Takehome et al. Found that prior to 2000, there was an average of 2 cases of Odyssean malaria a year, with the majority of European cases presenting in June, July, and August months, which are generally considered to be summer in most European countries. Locally, in 2017, the NICD confirmed that a case of 69 cases of Odyssean malaria had been confirmed in South Africa since 2007. The vast majority of these occurred in Gauteng. 2014 article by Frayn et al. Conducted a study to evaluate outbreaks of Odyssean malaria in Gauteng between 2007 and 2013. They found that there were 14 lab-proven cases of Odyssean malaria with 2 deaths, and this translated into a fatality rate far surpassing South Africa's case fatality rate for malaria. Importantly, the article stressed that South Africa's rate of undiagnosed Odyssean malaria could actually be far higher than we actually know. Their analysis indicated that signs and symptoms of such cases are often mistaken for sepsis, viral hepatitis, and influenza. And currently, the obvious misleading infectious culprit would be SARS-CoV-2. The study also determined that the vast majority of South African Odyssean malaria was due to vehicle-related vector transport, with Gauteng's role as an economic hub driving its relatively high caseload. In a study entitled Estimating the Malaria Risk of African Mosquito Movement by Air Travel, Takehome et al. Explained how conditions need to be appropriate enough for vector mosquitoes to survive for a sufficient amount of time in order to transmit Plasmodium falciparum. As a result, the window period within which the vector Anopheles mosquito has to inoculate is actually relatively narrow. The relatively unique climate of the Western Cape, with its winter rainfall pattern in comparison to endemic malarial areas in the northeast of the country, could be a contributing factor in the comparatively low number of Odyssean malaria cases presenting in the province. But there are also obviously additional factors that need to be taken into account, like distance from malaria areas and migration patterns. Our case stresses the importance of maintaining a degree of clinical suspicion, even if the history is not suggestive of malaria acquisition via travel to an endemic area. Crucially, it also demonstrates how COVID and malaria can present in very similar fashions. Recently, the NICD released a communique in January regarding 2 cases of Odyssean malaria in South Africa. The patients in both these cases had traveled, but had not entered known malaria areas. COVID-19 was suspected, but ruled out following negative test results. Malaria was then tested for based on the clinical picture of the patients, and the diagnosis was then settled on. This, along with our particular case of interest, raised the importance of maintaining a wide differential whilst also paying heed to hints of malaria, even if the travel history is not suggestive. The current climate of high COVID-19 prevalence clearly complicates matters, as presentation with shortness of breath, fever, and constitutional symptoms like myalgia and malaise, amongst others, are common in both illnesses. In these cases, a thorough patient history is still of utmost importance, as the majority of malaria cases are non-Odyssean. This interesting case from this week also raises the importance of the possibility of dual infection with both COVID and malaria. A similar case was actually treated at Takehome Hospital in March 2020 and was written up by Parker et al. For publishing in the Journal of Medical Laboratory Science and Technology. This was cited as the first case of dual malaria and COVID-19 infection that had been published. And the patient presented with a fever of sudden onset with no respiratory symptoms, as well as a history of travel to an area of endemic malaria, specifically being Mozambique. As a result, she was tested for both SARS-CoV-2 as well as malaria. Both the COVID PCR and malaria rapid antigen test came back as positive, indicating that she was duly infected. The species of malaria was then confirmed as Plasmodium falciparum on PCR, whilst the response to artemether lumefantrine treatment was monitored by microscopy. The article indicated the importance of PCR due to its greater sensitivity when compared to microscopy, in addition to its superior ability to determine species. The authors noted an increased gametocyte level, which they noted as being abnormal. They then hypothesized that this may have been due to a concomitant SARS-CoV-2 infection, which could have increased their stress response, resulting in an increased ratio of gametocytes. In addition, they suggested that mild malaria symptoms experienced by the patient could be due to a possible effect of COVID, resulting in an abnormal intracellular development of Plasmodium. However, the paper stressed that far more study was needed on duly infected patients before any genuine links could actually be determined for sure. So in terms of our case, the patient received IV artesunate for 3 days and then was switched to oral artemether lumefantrine. And she was actually discharged on Wednesday, and she's going to follow up in the ID clinic, and she seems to be doing very well. Okay. So just some take-home points. As a student, still very new to the field of medicine, this was an incredibly useful case to observe. The case stressed the importance of bearing in mind Odyssean malaria in patients with febrile illness, thrombocytopenia, as although rare, it is a deadly diagnosis to miss. The case also revealed how the current pandemic has introduced a new differential that can complicate matters. Clinicians obviously need to have a low threshold for performing malaria diagnostics when the picture fits. And also more work is probably needed as to whether active SARS infection can ultimately erode presentation and vice versa. And yeah, that's my story. I'd also just like to thank Prof. Mendelson and Dr. Pappas and the ID unit for their assistance, as well as the hematology department. Yeah, thanks.
Great, thanks very much indeed, Michael. If you can, Tara, if you can stop sharing the screen, then we can go to a discussion. That was a very nice presentation, Michael. Thanks very much, and particularly, as I said, to have done so in such a short time is great. So thank you for that. So again, really pleased that we've got Lucille, John, and Maria to join us. Lucille, maybe you'd like to start off. It'd be great to hear views on from all of you on the case and on anything else that you felt was good to talk about.
So very well presented, Michael. I think she's a very lucky patient. Why did she have a full blood count? In most instances, patient with a cough, particularly June and July of this year during the third wave, they simply would have stopped at a COVID test, particularly if the patient wasn't admitted, and you said she wasn't very unwell. So I think the full blood count was really a lucky stroke. And the thrombocytopenia, which is not really a finding in COVID, and the review of the slides really saved her. Most of these patients are picked up late when they have severe illness, and they don't all make it. So, you said you must think of malaria when the circumstances would suggest it. Well, there was nothing here that would have suggested the cough, the fever, travel to areas where Odyssean malaria is not even well described in June. I think she's very lucky, so very well done. I think what's much more common is during the season in malaria areas where people have forgotten about malaria, and particularly with patients with ARDS, they simply look for COVID and don't even bother about malaria, but ARDS occur obviously in both. So malaria is being missed. Thanks very much. I'm sure the others have got lots to.
No, thanks, Lucille. Yeah, I mean, I guess as you say, the thrombocytopenia was out of keeping with COVID, and obviously, very well picked up. I'm not sure who actually asked for the film.
Blood counts are not routinely done on all COVID patients.
No, I agree.
They're not admitted. So,
sure.
Wow, lucky person.
Yeah, very. John, perhaps we can ask you. I mean, you've seen a lot of these cases, and as you've published and make the point of the really very high mortality related, obviously, to delayed diagnosis. But I mean, obviously, if there's anything particularly you'd like to share, but I wondered also what you thought about the case from Tygerberg and their hypotheses that there may be an effect on gametocyte generation or numbers, and potentially whether there's any possibility that the two infections are interacting to change presentation.
Well, I did note the comment about gametocytes. It wasn't very convincing on the film, and I wonder how accurate that identification is, because really in falciparum, gametocytes only appear after about 2 weeks. They take much longer than with the non-falciparum species. So she would have had to be ill for at least 2 weeks before gametocytes appeared, and I didn't see any on the thick film.
No, I think they were, John. I think that this was the Tygerberg case, their paper that they published of the dual infection. They were suggesting that there may be an effect on gametocyte generation or appearance.
Oh yeah, I don't know. I haven't read the paper. Sorry.
That's fine. No. How do you think SARS and the Plasmodium might interact? Is there a possibility of interaction to change presentation?
Well, they're both, from an immunological point of view, both complex infections. So I guess there might be sort of, I mean, this is really out of my field, really. I'm talking. Sure.
Sorry, I'm putting you on a difficult position. But in terms of,
if I can just quickly update the situation in Gauteng. In fact, since those cases in the communique, we've had a total of 8 this year, including a very interesting cluster in a mother and two small children. Fortunately, all have survived. But in most of the cases, COVID was the first thought of the people assessing them for the first time. So it really is an important confounder. And I think certainly those 2 young twins were really lucky to survive. The diagnosis was really only made just in time. So overall, the mortality rate since 2000, it comes out at 15% mortality for these cases.
Well, concerning. No, thanks, John. And Maria, from an entomological point of view, what lessons can we take, and what were your thoughts?
It was a very nice talk, thanks. So I don't know, it is difficult, but when we go and investigate these cases, we normally do look for the mosquitoes. So we'll do a house search and see maybe the person brought the mosquito home with them. That can result in more infections within the family or nearby neighbors. We'll also look for any potential larval sites where a blood-fed female could possibly oviposit. Because then if we do have malaria around, we could actually get more cases if the mosquito is there. But it's not often that we find the mosquito. Actually, hardly ever. Can happen.
And I mean, the species in the ones you have found, are we able to, do we know anything about the Anopheline species that it is?
So it would be probably Arabiensis in this country, but there could be others. There are other minor vectors. There's Vanessa's positivism.
Are there, I mean, an entomological control at borders is obviously pretty difficult and fraught with problems, but is there any, I mean, are any of the containers or lorries or anything sprayed or sampled? Do we know anything about that at the borders?
I'm not too sure, sorry. I don't know about that.
Okay. I can answer that. Sorry, Maria.
Go for it, John, thanks.
Yes, that's often suggested, Mark, but if you look at the logistics of it, it's really impractical. It's really impossible to do that. If you look at the volume of vehicles and traffic, we do in these sort of commentaries suggest that people might consider dooming the insect, dooming the inside of their cars, but I think that's also not really practical to expect. And it's in terms of the volume of trucks and containers and things like that, it's just not a practical.
Yeah.
It's more important to alert clinicians about the possibility.
Absolutely. Fantastic. Thanks very much. So I'm not sure if any of my colleagues would like to. I think Sean has his hand up. Sean.
Thanks very much, Boyd. That was really impressive work, and I really enjoyed it. Well done. It's not every day that you get to speak to an entomologist. So I have some detailed questions for Maria. So I'm trying to understand how this works from the mosquito's point of view. does the mosquito kind of just get onto a transport? How long does it lay eggs there? Do the eggs then hatch in a foreign environment? Can this kind of spurn more mosquitoes? And how long does the mosquito live for? You know, can you give us more details? It's really interesting to think about this.
Yeah, so the mosquito will probably just travel in the car with you. It's not going to lay eggs in there. But they do need the blood meal before they can lay eggs. If they do get to a suitable area and survive, then they could lay eggs. Yeah, then you'd have to be aware. But I don't know. I don't think the chances are not very high. They can survive maybe about a month, usually a bit less, approximately 2 weeks to a month, I'd say.
Thanks.
So if I can add to that, Sean, the real reason that we get our entomologists to investigate these cases is not because we expect to find the mosquito, because usually transmission would have occurred 2 weeks or longer before the case is even recognized, and often substantially longer. But the real reason is what Maria pointed out, that once a mosquito has taken a blood meal, it wants to find a place to lay eggs. And if the climatic conditions are okay, which would certainly apply to Gauteng and Pretoria or Johannesburg and Pretoria in summer, then we may get local breeding. And that might, in theory, if there are gametocyte carriers around, lead to a localized infection. But as Maria said, we've actually never documented this, fortunately.
Okay, no, fantastic. Thanks. It's been wonderful to last quick comment from or question, two last quick questions from Elizabeth.
I assume there was no blood transfusion at any stage. Even for Odyssean malaria, the travel history is unusual for that area. Most of ours are from Mpumalanga, Mozambique. We're on the road, whereas Eastern Cape isn't quite. It would have to be a 2-hop thing for the mosquito.
No, there was no blood transfusion. Elizabeth, the last point.
Okay, just quickly, I was going to ask, with climate change and heating up, are you worried that the malaria area might extend into Joburg and Pretoria? Well, Pretoria, possibly then to Joburg.
John or Lucille, do you want to answer that?
Well, I think the effect of climate change on mosquito distribution are variable. There's evidence, I think, from East Africa, and Maria can confirm this, that the distribution in, I think it's Kenya, has actually extended to higher altitudes than in the past. But the other side of this is that some places may become drier and less hospitable to